So next I'm going to show you the data for behavioral health. And we really focused on showing you the primary care data from Washington because they're the ones that actually did it really well. I will say that a lot of these systems have since really ramped up a lot of their work in primary care as well. So this was 5 years ago that this ended, and we had to end it then because of COVID. It's really hard to measure suicide attempts in emergency departments when the emergency departments were full of people with COVID and people weren't going to the emergency department when they had a suicide attempt. So the rates did not go down. People weren't going to the hospital, so it was a lot harder to measure. So we did this in behavioral health, and we had pretty robust implementation in all the behavioral health settings. So we wanted to take a look using an interrupted time series design, which measures rates, monthly rates of suicide attempts and deaths during a pre-implementation phase, and then measures an interruption time point when the intervention was actually implemented. So this is the points at which you saw those huge curves go up. And we started at the point at which we started seeing the curve move. That was the date of implementation in that system. So each system had different implementation dates. So we measured implementation start and stop. Well, there wasn't really a stop, but start at the point at which the implementation started rising. And then we marked that date and then did a segmented regression. We're getting a little nerdy right now, but it basically is looking at one model and then comparing the regression line or the slope with the slope after you implement. And it accounts for what the expected rate would be. So you can see whether or not there's a departure. And this is how you measure the effect of policies really well in an entire community, because you can't randomize 10 million people to an intervention per year and say, okay, half of you get these great services and the rest of you do not. You can't do that. Ethical problems, there's way too many people, you just can't do that. And all of these health systems decided to do this all at once. So we wanted to measure, and there's hundreds of thousands of people who had behavioral health visits. So what we saw was that in 3 of the 4 healthcare systems that had new implementation during the observation period in behavioral health services, we saw statistically significant reductions in suicide attempts and deaths, including up to about 0.7 per 100,000 per month, which was a pretty remarkable reduction. This last system, Site D, so there's a couple things. Number one, this happened during the transition from ICD-9 to ICD-10. And what happened in the United States, all the rest of you transitioned like 30 years ago. In the US, we decided to do this in 2015. And so what happened is that you can see that implementation mark is exactly at the time point that we transition. And what likely happened there is the old scheme for measuring, we weren't really able to capture suicide attempts as well. So these estimates are all very conservative because the pre-period likely had significantly higher rates than what we're measuring in the post-period after implementation. So these are really conservative estimates. And I'll also say that another thing that we typically see in a lot of health systems that I think that we clearly saw here, and what I've seen in several other health systems that haven't published any of their stuff, is that right after you implement, you see this big bump up. And that's because people start paying attention to it. Now, all of a sudden, they start paying attention to measuring suicide attempts. So I think, those are a couple of the reasons we think that this might have been like that at System D. But after implementation, we again saw a gradual decrease in the suicide rate. Now, these are small graphs, so it's hard to tell how much of a difference it was making. But if you think about hundreds and hundreds of thousands of people, millions of people having reductions of suicide attempts by what you see in some of these sites. The other part of this story that's pretty remarkable is in Health System Y in the bottom left-hand corner here. That's Kaiser Washington, who agreed to publicly report which site they were. They implemented right at the beginning of this phase. So we don't have pre-implementation rate data, but they have had a consistently gradual decrease in their suicide attempts and deaths every single year since they implemented this program. So not only have they seen a reduction, but they've also sustained it and sustained it over a decade, which is pretty remarkable. And you can see Henry Ford's rates in the bottom right corner. Obviously, we've had a low sustained rate, reflecting the fact that we've had this program going for 20-some years in behavioral health, and have a suicide attempt and death rate that's actually lower than, in our behavioral health department, that's lower than the national average for the general population. And so you can see that pretty much in all of these sites, we're seeing an impact. We're seeing that implementation of this approach led to reductions in suicide attempts and deaths at different rates based on how these systems implemented their programs. So we have a lot to learn about the different approaches of implementation that we can continue forward and help inform everybody else about how to do this. Amazing that this is the first data that we've ever had that really shows, outside of Henry Ford, that this works across lots and lots of places across the country. And of course, Centerstone has shared their data, but we haven't had real published data. So that paper is under review right now, and hopefully someday will come out. It's taking forever, believe me. I was hoping it'd be out by now, but it's not. So I will definitely send that around when it officially gets published. We have stimulated a lot of work, and I want to thank our team for My Mind, who this is our statewide program. We have the SAMHSA program, which was really trying to innovate new methods in the emergency department. We had seen a gap when people screen positive in the emergency department and then get discharged to home. There's a lot of people that go to the hospital or something, med surg or psych units, but a lot of people go home, and they are just out there in the abyss. So we really needed to close that gap. And so this program has really allowed us to do that, and it's been a really great program. And of course, I'm highlighting Zero Suicide International in the middle here, because that's all of you who are doing this work, who now have even more evidence to show that this works and can continue to push forward. I don't think we really need anything else to show that this works in the United States, at least. I also want to champion some of the work we're doing internationally that's stemming out of all of this effort. We have several of our colleagues from Nepal here in the front. This is our first really big-time international effort. We're doing a ton of great work there, and Deepak is here, and we have some representatives from across the country, the government, health systems, who are working in partnership with us for an entire national initiative that we're building right now. And we really think that this is an opportunity to do something a little bit different, to reach people that don't have access, to reach people that have different kinds of communities and resources. You'll notice that most of the places that we've done this work have been in higher income countries, and we want to think a little bit differently, reach a little bit further, innovate, adapt, and really partner with people across the world to help build communities that can work across these regions. We just had a paper that came out a couple of weeks ago in the Asian Journal of Psychiatry that really featured a little bit of the work we're doing in Nepal, as well as all the partners that we're at. You have a big panel today that we're really excited about, related to all the work that we're thinking about in Asia. And so I'm going to stop there, but rather than asking questions right now, I'm going to hand it over to Sue, and then let Sue go. And then I'm going to skip through this, because this was just extra slides that we had in case there were questions. Okay, so I'm going to let Sue go, and then we can ask questions. So start thinking about questions, and also, if you have that QR code and you want to put it in, if you want to just type something, please do. We're happy to answer anything, and we'll leave quite a bit of time here to talk a little bit about these studies.